Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Today, we're celebrating National Nurses Week and highlighting some of the nurses and nurse practitioners who help keep this health system running. You know, doctors can't do it alone. For example, in the outpatient world, I work closely with Joyce Funk, who's an outstanding nurse practitioner, and she is the brain, the heart, and the soul of our clinical practice. When I'm on the inpatient rounds, Jamie Clam is a star. She is a nurse practitioner who is caring for cystic fibrosis patients here on the inpatient side of our health system. When I go to rounds, Jamie has it all figured out. There's really not much I need to add. We're about to meet nurses who are managing some of the most important aspects of our entire health hospital: wound care, pain management, and infection prevention and control. We'll also hear directly from a patient and learn what excellent nursing care has meant for him. But first, let's do morning rounds. Mammogram recommendations have officially changed. A panel of government advisors called the U.S. Preventive Services Task Force now says all women age 40 and older should get a mammogram every other year. Previously, they recommended starting at the age of 50, but these new recommendations aren't exactly in line with the guidance from groups like the American Cancer Society. We're joined by Dr. Annalisa Winblad, who is a breast imaging specialist and the director of breast imaging here at the University of Kansas Cancer Center. Annalisa, welcome onto the program.
Thank you for having me.
Well, we're delighted to have you. Tell me, what science or data justifies dropping this age from 50 to 40?
Breast cancer is really common. 1 in 8 women will be diagnosed with breast cancer in their lifetime, and 1 in 6 of those women will be in their 40s. In fact, most of the years of life lost due to breast cancer are from women aged 40 to 49. New studies show that when women are screened every year beginning at age 40, breast cancer death rate decreases by up to 42%. And the task force agrees that screening should start at age 40.
So how come the American Cancer Society hasn't gotten in line with that?
Well, most groups recommend starting at age 40, and most groups actually recommend starting every year at age 40. The task force has not updated those recommendations. They still recommend every other year, but most groups, most medical societies recommend screening every year beginning at age 40. We know that when women skip a mammogram, they're actually more likely to present with larger tumors, tumors that have spread. They're more likely to die from breast cancer or have worse outcomes. So we know the very best method for screening is to start at age 40 and every year.
So why are some of these guidelines talk about every other year? I don't get it. You know, some are 40, some 50 every year. To me, I'd want to have patients be the safest.
You know, and it's interesting because the higher grade cancers, the more aggressive cancers, those are the cancers we want to find early because they grow fast. They're more likely to spread quickly. They're more likely to kill a patient, to cause breast cancer death. And when we screen every other year, those are the cancers we're going to miss. Those are the cancers we're going to allow to grow and spread. And those are the cancers that cause harm for our patients. So screening every year doesn't make sense. It doesn't go far enough for our patients, especially for some groups of women who are at even higher risk.
So what do the new guidelines say about the racial disparity that are impacting African American women?
So Black women are actually more likely than white women to present at a younger age with breast cancer. They're more likely to have aggressive types of breast cancer, and they have worse outcomes. In fact, Black women are 40% more likely to die from breast cancer than their white counterparts with breast cancer. So these screening guidelines simply don't go far enough. Patients need to be screened every year. In fact, I recommend that all women have a breast cancer risk assessment by age 25 to determine if you should start screening before age 40.
So these guidelines are based on age. Could we think we'll see one day any more precise, personalized recommendations based on an individual's risk?
Absolutely, and in fact, we already do this in many ways. Of course, age is a very important risk factor for breast cancer, and many of our guidelines recommend a starting age for screening. However, we know that some patients are at higher risk. This is one of the reasons that breast cancer risk assessment is recommended by age 25. If we identify women who are at high risk, we actually recommend earlier screening, and we recommend screening with not only a mammogram, but other types of screening tests such as breast MRI. So we do have high risk recommendations that are personalized for individuals. Once a woman starts screening, we also have personalized risk assessment based on breast density. And for those patients, we also offer and recommend additional types of screening in addition to mammogram. So this is already happening.
Yeah, it sounds like that, which is really important. Now, there is still an incidence of breast cancer in men, especially with who may carry the BRCA1 or 2 mutations. Talk to us, when should they get started?
So male patients, you're absolutely correct. We see male patients with breast cancer. Certain male patients with genetic mutations are at higher risk for developing breast cancer and should be have a risk assessment by a provider who can let them know when screening should begin. We actually have several male patients at KU who screen every year with mammogram, and that is recommended in certain high-risk groups of men.
All right. Dr. Wimblett, thank you. Thanks for being here this morning. Thanks for helping us understand some of these differences and for leading the charge in such an outstanding way here at the University of Kansas Health System. Thank you so much. All right, let's just turn to some of our expert nurses who are helping lead certain teams that traditionally you might have expected a doctor to be in charge. Lance Williamson. Now, you know Lance from back in the COVID days. I said when I walked in, I was like, I'm so glad to see Lance again. Lance Williamson is a manager of infection prevention and control. Carla Oberly is the nurse manager for our wound and ostomy team. Jennifer Surprise is an advanced practice registered nurse, clinical nurse specialist on our pain management team. And I'm sitting next to Bob Harrison. He's not a nurse, but he's spent quite a bit of time as a patient here at our health system. Bob, we want to hear your perspective first. Talk to us a little bit about what has been so important for you around nursing and what brought you here to the health system to begin with.
Well, 2 years ago, about this time, I noticed some blood in my urine, and the next day, the very next day, I went to see my urologist, and she was with KCUC. Now, KU's reputation speaks for itself. So what I did was I was referred over here to KU from my urologist over there at KCUC, and it's the best thing that ever happened to me. I went over there and I had chemotherapy, then I had my bladder removed, and I'm cancer-free at this point and living life the way it's supposed to be.
That's awesome. Now, you met a lot of nurses while you were on this journey, and you told us, though, there was one nurse in particular you'd like to mention. Who was that, and tell us why?
Well, her name is Stephanie Winwright, and she was so diligent in making sure my trip home was going to be ready to go. When I was here, I was kind of out of it at times. But she came in, she taught me how to use the equipment I had. She was just a wonderful person to deal with, and a Daisy Award winner.
Which is a big
last
deal here in
year,
our
which-
health system for outstanding
So I've
nursing
heard.
gear. Yeah, that's a big darn deal.
So anything she gets as far as accolades, she is a credit to profession.
You know, I think people look at it and they say, oh, the physician did this, physician did that. What they don't realize is really the nurses are doing a lot of the work behind the scenes and are doing the things that help enable patients to have a good recovery. You can do the best surgery in the world, but if the wound isn't taken care of afterwards, that's a bad outcome. And that sounds like you had a great experience.
That's exactly what it is. I'd love to recognize all 247 nurses I had at KU.
You kept count, didn't you? That's impressive.
You said my time is limited, so
Yeah.
I'll just thank them all
Okay,
as a whole.
good. I told him before the program started that if people start going too long, I'm going to go, and he said, I won't recognize 247. Thank you for that.
You're
I
welcome,
knew that.
Dr. Stites.
Or Carla, what's your response to hearing this kind of praise from one of your team members?
It's not surprising. First, Bob, thanks for coming in and sharing the story again. I got to hear it when Stephanie did win the award a year ago. But I will say it's just a testament. It's not just a job. It's not at this level. You know, her expertise and compassion, I mean, it's not surprising. I have a group of 6, and I would say that's the care that each and every one of them provide. So very proud of what they do.
So wound and ostomy team nurses are some of the nurses that can actually place orders in the chart to get things executed, et cetera. Something that's normally reserved for physicians, advanced practice providers. But what orders can a wound nurse place, and why is having that power so important?
You know, about a year ago, I think what we noticed, and a lot with the clinical excellence team, services, pain and ID and palliative and diabetes, so important to the patient outcomes, but that they would write the recommendations in their note, and sometimes those aren't immediately getting implemented. And in the world of wound and ostomy, it's imperative that these patients get the treatment sooner.
Right away.
And so, you know, we're lucky to have Dr. Orr, medical director in wound and hyperbarics, that championed this protocol that was built called the Impaired Skin Integrity Protocol. And so now that allows the nurses on the wound team to then go ahead and implement the orders. And particularly, it's topical treatments for wound and ostomy. So nothing like antibiotics, that would be reserved for the providers. But it's getting patients care sooner. So that was the whole purpose behind
that
it.
worked well for you.
She's speaking right to actually how it is.
Yeah, she is. Well,
I mean, I have everything I need at home, and I never have to worry about being out of anything. And thank you.
Yeah.
You know, when I'm in a field, I don't write orders for something that I'm not comfortable with. I could never write the orders for wound and ostomy care.
Yeah.
So I'm so glad you all do that, because it makes the patient's care much easier. It makes our jobs a lot better to have people who really know what they're doing writing those orders. So thank you for that. Yeah. So I'm going to turn now to Lance Williamson. Now, again, you may remember him from being one of our great voices of reason about infection prevention control throughout our pandemic. Became being one of our top and most important advisors here, along with Amanda and of course Doc Hawk. Help explain what an IPAC nurse does, though. Tell us what we mean by when we say infection prevention and control.
Yeah, well, it's not always responding to pandemics. That doesn't come around but every about 100 years so far.
Yeah.
So,
well, let's keep it there.
Yeah, I know. But what I love about infection prevention and control is that it's different every day. So we do all sorts of things. You know, one day we could be working with our construction and renovation teams to make sure that construction barriers are in place and appropriate so that construction dust doesn't impact our patients and cause infections in them. And then the next day we could be investigating an outbreak. We function kind of like a small health department for the city that is our 17,000 employees across the system. So we get to do all sorts of public health things, and it's really fun. It's always different every day, which is why we all love to do it.
You know, I can't say enough good things about the tremendous work our team did during COVID, but really every day, because one of the things at a hospital like ours is that we have really sick folks, and some of them have really resistant bacterial infection. We can't spread that to another person. Part of that means you have to have the right equipment, the right protection, You created some visual reminders for best practices in PPE. Tell us a little bit about that idea.
Yeah, so we partnered with the media and communication teams to do a photo shoot. We do a lot of stories about tips and tricks for folks to use PPE appropriately so they don't spread germs. That's really our #1 goal. And we were looking at stock images and we're like, let's, why don't we get a photographer in and take our own photos of exactly what we want to see and to show. And so, yeah, you can see there that we're really focusing on what are the subtle details of your PPE that maybe can be missed easily, either if you're in a rush or really any other reason. And so we're really focused on what we can do to reduce that cross-contamination from one patient to another, and that's really the reason why you wear PPE, is to protect the next patient from whatever germ is happening with the previous patient. There also is a personal protection, a la the name of it, aspect of that, but really what we're trying to do is make sure those germs don't spread from one room to another, one patient to another, and keep patients safe.
And when you deal with, I mean, I deal with really infected patients with lots of different bacteria. It is just so important. So how do I do when I put my gun on?
I reviewed that video and you did very
okay?
good. Yeah, you did really good.
All right, thank you. Hey, you know what though? It is true, because I remember when I first started in medicine, people did not wash their hands between patients, right? That was not something we did. Now, when I come out of the room, if I don't do it, I'm like, God, where's the little alcohol?
Yeah.
So you guys have really brought us a long way.
Yeah, we've learned a lot, and I think it's on what there are some silver linings, I think, to what we experienced over the last several years. One of those is that I think the population at large understands the risk of germ transmission. We kind of went a little too far for a while, right? But how I measure it is my dad now washes his hands regularly, and he never did before.
Your dad and I are probably the same age, so that's probably good.
Yeah, so once it kind of hit home with him, that was, I knew that, I think this is reaching people now. Obviously there was a lot of terrible things that happened, but that I think is on the top of everyone's mind, and that really helped us now, where people are thinking critically about germ transmission, whereas before, it was kind of out of sight, out of mind. And I think now we have a nice balance, and that is really where we want to be.
That's awesome. So the nurses and you guys, you do extra preparedness training in case somebody walks into the emergency room with something like Ebola or some other terribly contagious disease. Mm-hmm. How do you stay ahead of that curve with all the different bugs that we know are out there?
Well, I do have, I still have my Google alerts that I set up during COVID of like every, CDC, other words that we're looking for to make sure we're staying on top of the news. And also, we have connections with, so we're a conduit with public health departments, both local and state. So we work really closely with KDHE. We do sometimes get to work with CDC, which is really fun and it's exciting for people like me. And so we're trying to, use those connections to make sure that we're ahead of the curve there and we're prepared. And, our regulatory compliance, we have to be prepared because of our station here in the region. We need to make sure that we can take care of these patients. And so we do try to keep that preparedness all the time and just be ready for anything. And that's another thing with COVID, is that we've been through a pandemic, and so that's probably one of the biggest, worst things you can go through in terms of infection controls. So we do feel better prepared now because we know we can handle it.
So last time I was going to say, I know I geek out over Star Trek, Live Long and Prosper. I think you geek out over the CDC. That is what I just heard.
Well, yeah, we all do. Yeah, my team, we...
which is, thank goodness you're here to do that.
Yeah, thank you.
Jennifer, you're in pain management. Are you guys typically helping patients with acute pain or chronic pain or both?
Usually a little bit of both.
Yeah.
Yeah. I mean, it's rare that we just go and see somebody with, they've had a knee replacement or something. These are people who have had persistent pain for quite a while, and then they come in the hospital with a new situation or some illness, injury, whatever. So that's generally the ones that we end up seeing.
So how do you approach diagnosing the underlying cause of chronic pain? I mean, that can be really complicated. There are a lot of layers to it.
Yeah. Thanks for that one.
Yeah, you're welcome.
Yeah.
I'm here for you.
I've been
you and I have worked together many times with you. It's some of my challenging. Sometimes patients with chronic disease can be pretty challenging because they have a chronic disease and they have chronic pain, and you got to try and and they suffer.
Yeah.
And you have to try and unwind all
and
that.
so that if a person has persistent chronic pain, a lot of times what's happening is they're going through you know, they're living with whatever the illness is, the background, and then they have the emotional responses, and then there's this whole there's a whole psychosocial. So we see the whole person, and how do you decide if the pain is from something that is cutting them at that moment versus the existential type pain that people are having, and it takes a long time to start looking at that. And really, the best thing that I can offer that my team does, and we're a team of 3, is sitting down and listening to our patients. Just let them talk to us, because sometimes that's the only way we get really what is going on with what's happening with them.
You know, it's challenging right now in pain management, isn't it, with all the concern about narcotic addiction, et cetera. Talk to us a little bit about how you handle it around this whole concept of too many painkillers, or
Yeah, you know, from my point of view, I've seen it. You know, I've come from where no one got pain medications because we didn't treat pain as well.
Right.
Then we went to that pendulum that swung to everybody gets whatever they want. Zero pain. We have to bring that back to the middle. And so the challenge is really looking at the different options that we have. You know, we have wonderful anesthesiologists that do tremendous work in modalities, the interventions, but also we have to bring in the idea of you need to help yourself and empowering the patients themselves. And so we as nurses need to, you know, I think our goal here is to provide empathy and understand that they're having the pain, but then bring with them along, you know, help walk along with them so that we can actually empower the patient to say, you know, some of these things might hurt you more in the long run.
Absolutely.
So we need to find some other way to help you.
There has been the rise of some of the non-pharmacologic treatments for change, whether pain, whether it's cognitive behavioral therapy, et cetera. Talk to us about some of those.
You know, I mean, we go from even the minimalist of everybody gets a heating pad in this hospital, unless they've got a burr or an ice pack or whatever. But all the way through to, like you said, you know, I actually taught a class. I taught a class through the Turning Point about empowered relief, and that was an awesome, you know, ability to really talk patients through why we have pain, but how you perceive it in your brain, and then how you can work through that using audio tapes and relaxation and, you know, to everything. I mean, I'm a huge fan of physical therapy from my own personal experience, and my father's had an amazing response here with PT. So there's a whole range of things that I don't think people know. I don't think they understand it's there.
There are a lot of choices out there.
Yeah.
Okay, so to our nursing team, if a patient comes in and says, I don't want to see a nurse, I want to see a doctor, how do you handle that? Because sometimes that's not the right choice. They need to see the nurse. Go ahead.
Well,
somebody.
I would almost say opposite for my team. If anything, a lot of the patients that the wound ostomy team see, they see them from the beginning and throughout. And so there's a trust and a relationship that forms. And often I actually get the request, like, where's the wound team nurse? I want the wound, I need the ostomy nurse. And they know, and they've developed that relationship. So I would almost say for my group, it might be opposite.
Wow.
You may have something different to say.
Oh, we very often, we have, you know, we have a lot of patients that we see repeatedly. They come in the hospital for their illness and we see them again and again. And very often we are the people that hold the understanding from moment to moment, from encounter to encounter. And they're the ones, they'll say, we need to see them because we've had this whole conversation before. And so my hospitalist has changed every week, but we're the constants, and the nurses are the constants. And so we help pull together, you know, and advocate for our patients by being there with them right at the bedside.
I know when I go to see one of my patients at the clinic and Joyce isn't there, the first question I get is, where's Joyce? Well, that's smart because she is the constant every single day. All right, we are here to answer some of your questions. Send them using the links on your screen from YouTube, or to YouTube, Facebook, Twitter, or email the Medical News Network. So the COVID count's over. Long live COVID.
Yeah.
Nope. But Hawkeye is still here for a new segment we're going to call Hawk Talk. And right now, he's over in the Hawk's Nest to do the Hawk Talk. Dr. Dana Hawkinson is the Medical Director of Infection Prevention Control. And I think we'd agree, Hawkeye, that we rely on nurses like no other.
Yeah, you know, I do want to give a shout out and accolades, especially during Nurses Week, for the IPAC team that I work with. When you hear Medical Director of Infection Prevention and Control, that's what I do. I work directly with Lance and the infection prevention and control nurses on a daily basis. They just have so much activity in helping patients and employees stay safe around the health system for many different aspects. It's not just infections, but it's also things, everyday things, surgeries, understanding what are the processes going into that and keeping people safe, but also just around the units, such as the alcohol that we can use for our hand sanitizer to do that, to keep our hands clean. So they have just a lot of activities that they do to help keep patients and employees and, of course, families safe as well. It's so good to work with them, and Lance and his team is excellent.
You know, there is a ton of attention on bird flu and H5N1, but Doc Hawk, you're still dealing with the rise in sexually transmitted infections. Yeah. In your words, syphilis is raging. What's up?
Yeah, you know, for the last couple years, we have certainly seen increases in syphilis in our own practice, but we know around the nation, the numbers have been extremely high the last 2 or 3 years. This goes for not only syphilis infections by adults, but also, unfortunately, congenital syphilis infections, so when mom can transfer it to baby as well. These infections are on the rise. I think a lot of it has to do with public health infrastructure and funding and the ability to get the education out to people to understand to go get tested on a frequent basis, especially if you are involved with multiple partners or may think you have had exposure. It's very important to have access to places where you can get tested frequently to get treatment. So, all over the nation, especially in places like South Dakota, Ohio, but there are many places other than that as well that have seen rises in syphilis cases, but also, unfortunately, congenital syphilis cases, which can affect baby in many different ways.
So we're keeping tabs on Mpox, which is formerly called monkeypox. There is a vaccine, still outbreaks going on in New York City and Ohio, though.
Yeah, and this is also a disease that can be considered a STI or sexually transmitted infection. However, it doesn't have to be. This is a disease that can be spread just by general contact, but also contact with clothing or bedding or anything else of that nature. Anything where if somebody does have Mpox and they have wounds and they're able to shed the virus onto fomites or inanimate objects such as bedding or clothing, and people use that, they can get infected as well. But we have seen just increases in rise in Mpox cases. I think beginning in 2022, there was a huge outbreak globally. The cases somewhat trailed off, but they never went away. And then now we are seeing, especially in New York City, they are having a large rise in their cases as well. But I think it is important, just as you mentioned, Steve, that there is a good vaccine that is available that does offer very good protection against disease, and that is the Jynneos vaccine. We have initially used it for smallpox vaccination, but this type of virus is the same general type of virus as smallpox, and so the vaccine for smallpox does confer protection, especially if you are up to date and you have had 2 doses of the vaccine. Now, the recommendation continues to be that those people who are at just highest risk for having Mpox or acquiring or having exposure to Mpox be vaccinated. There is not a general recommendation to vaccinate everyone. And for most of those people who are, it's recommended, it is just people at high-risk situations, certainly men who have sex with men group, as we have seen that the vast majority of people currently who have had Mpox or been diagnosed have been fallen into that category as well. So there are specific recommendations for that. Again, it's not for the general public per se, but it is important. Again, I think this goes back to public health infrastructure, being able to get that information out there, that education, and then having access to it as well.
All right. Thank you, sir. Always good to have you here, even if we're not talking about the word that shall not be named.
Yeah, when you first mentioned, though, you did say long live COVID. I would not put long and COVID in the same
No,
sentence.
that was my joke. You know, long live the Queen, long live the King. I was trying to be funny. Maybe it didn't go very well. That's not unusual for me.
No, but I
Bad
think it's an
jokes.
important point, though, Steve, and you have talked about this. We have seen this. Long COVID continues to be an issue for many people around the country, although over time we know that you can have a reduction or resolution of your symptoms. And we know that vaccination helps prevent or decrease the risk of getting long COVID. We still know that people are dealing with this on a daily basis. It is not a public health crisis per se, but it certainly impacts many people in the public realm on a day-to-day basis. And that is going to work, taking care of kids, just doing activities of daily living can be affected as well. So it is very important that we continue to address it, keep it at the forefront, and really try to answer the questions as to why, and then also develop therapies on how to make it better as well.
Totally agree, man. Thank you.
Thank you.
Hawk, always good to see you.
Yes.
Brother. All right. We know many of you may have some questions. Let's head to Studio B and Alexis.
We have so many great questions, Dr. Stites, but also a lot of love coming in for our nurses. So I want to read the love first. Cheryl White says, thank you so much for these weekly programs. Christy writes, nice to see nurses highlighted. They really are the backbone of healthcare, in my opinion, with a heart emoji.
Yeah, I'd agree with that.
And then we have another comment. Nursing has really evolved over the past 60 years due to all the advances. And then Ruth writes, we love our nurse practitioners at our primary care. Speaking for a lot of people who are so appreciative, including Bob, of the nurses that care for them. Stu has a question. This is a great question. Stu wants to know, besides COVID, what other infections would lead to someone being isolated in a hospital? And how many patients are in isolation at any given time?
Yeah, those are good questions.
That's a great question. All right, Lance.
Yeah, so we're keeping track of organisms of consequence, so germs that are either resistant to typical antibiotics. That is a fairly common reason why someone might be in isolation. And then the things you see in the news, so like measles, we'll isolate, and it's a different isolation for those. And influenza, we still see that. So some of those common ones that we see in the communities, those are reasons why we would isolate. We have a pretty low threshold in the hospital for recommending that isolation to protect all the patients that we have here.
Did you ever have to be in isolation?
I did. I don't know if I should mention what it was for.
Well, that's up to you. Your choice entirely.
It was C. diff.
Yep.
And it's something you get, I guess, when hospital stays, medications,
Antibiotics.
crossing back and forth. So
and it's a tough one.
I had that, and everybody came in like gowned and masked, and
Gloves.
the food came in on styrofoam, and it was there for probably 3 or 4 days.
And then you got better.
And then I became a real person again. And
Yeah, that's exactly right. So we want to not take what you have and give it to the next person.
Exactly.
That's what we do.
Exactly.
Yeah.
All right, Alexis.
Amy has a question about terminology. She writes, I know what an RN is, but what is an APRN?
Ooh, okay. Here we go.
So I'm an advanced practice registered nurse, APRN. There are 4 different roles that are in the APRN group. So there's the nurse practitioners, there's a clinical nurse specialist, that's me, there's nurse midwives, and then there's the CRNAs, so nurse anesthetists. So we're all under the grouping of APRN, and that we've gotten advanced education and then advanced licensure, and we're certified. So
what's the difference between a clinical nurse specialist and a nurse practitioner?
Oh, I should have my elevator speech. Generally, nurse practitioners focus on a patient, so patient interaction, diagnosing, treating, that kind of thing. Clinical nurse specialists can do that, at least in the state of Kansas. And then we can also, we work with the system. So I also work in writing policies and procedures and things like that. Yeah. And we also work with, educating our nursing staff, things like that. So it's a little bit broader than just what the nurse practitioner does.
One's a little more provider, one could be a little more policy driven and things. Yeah.
Yeah.
Cool. All right.
Jeremy has a very good question. He would like to know, what have you found to be the most personally rewarding part of being a nurse?
All right. Outstanding. I'm going to start with you.
Yeah, no, that's actually, I'm glad you started with me. That's an easy one to answer. I think most of us, I mean, at the table, and probably just any nurse in general, but it's about patience and taking care of people. I think there's something innate a lot of us have as far as wanting to take care of people and being nurturing, and I think those are important characteristics to have in nursing, and I think there's purpose. There's purpose in nursing, you know, and taking care of people and seeing them through their journey, whether you're in the hospital or the clinic setting, and just watching it from the beginning to end. It's rewarding. It's a rewarding a career. So.
Jennifer, what do you
Oh, I mean, I ditto what Carla said. I mean, I think that just being able to meet people and get very you know, we're very intimate with our patients, and so that really it's a relationship that some people would never be able to get again. It's just.
Lance?
Yeah, I think as a public health nurse and infection preventionist, I really like that we can impact populations, and we see that with all of the work that we've done. It's really rewarding, and I feel good going home after I do this work.
I'm glad you're here. What would you say your daughter, isn't your daughter a nurse here?
Yes.
What would she say?
Well, she is as nurturing as she can be, and lucky for her kids, right, and her husband, because she's that way. That's the way she's always been. I'm very proud of her, and sky's the limit.
You know, I think that empathy is something that we don't put enough value on, and the best nurses I know, it is a superpower, how well they can relate to people and help change the course of disease, the course of pain, the course of healing, the course of doing what you're supposed to do, because of the relationship our nurses have with their patients. It does make all the difference in the world. It's been great to hearing from everyone. I'd like to hear some final thoughts, though, before we go. Bob, I'm going to start with you.
Well, I really appreciate you acknowledging my thoughts about this profession. It's something I've certainly filled out a lot of online surveys for Mr. Page over the last couple of years, but to be able to do it in this forum is, I couldn't ask for more. Thank you, Doctor.
Thank you for being here. It's been awesome to have you. Lance.
Final thoughts. When you wash your hands, don't forget about the thumbs.
Oh.
Those are they're forgotten a lot.
I knew you were going to do that. That's awesome. Well done.
You know, I have a team, and I work with a team, and it's not just my team of nurses that we work together. It's the nurses on the hospital. It's the nurses on other places. So I just appreciate teamwork that we have here at KU, and I wouldn't go anywhere else.
I think for me, I kind of a little bit second what Jennifer's saying, but just with my team specifically, and all nurses, but specifically the wound and ostomy team, believe it or not, it's not a career path many nurses take. Not a lot of wound and ostomy nurses out there, people dying to do that, and so I just want to specifically say thank you to them and for the work they do. They put a lot of time goes into doing the preparation and the studying and the training to become a wound and ostomy nurse. So they're a rare breed, and I'm very proud of them and want to say thank them for everything they do for the patients here at KU. So and everywhere.
You know, I think the word you've heard a couple times today is team. I think about the Kansas City Chiefs, so I'm a huge Chiefs fan, and I don't care if you're Patrick Mahomes, Travis Kelce, Chris Jones, it doesn't matter. If you don't have the team around you, you're not going to do well, you're not going to perform well. There used to be a time when in medicine it was all about the doctor, and I thank goodness that time has passed, and for some people we still struggle with it, but by and large it's passed. And the reality is that we do much, much better, as we do in everything in life, when we work well as a team, because teamwork is what makes patients better, not in any individual person. Thanks again to all of our guests and to all of our audience. Remember, faith, hope, and science, and teamwork. We'll be back next week.
A routine visit leads to an emergency surgery. I'm Alexis Del Cid on the next All Things Heart. What happened and why she says she feels better now in her 60s than she did in her 30s.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.